And first of all, we have minutes to approve both.
Actually, we have not started the live stream yet. Julie is working on the live stream, so if you give just a minute.
I have to be pleasant again.
Yes.
I only have so much, so.
Thank goodness this is your
This
only
conference will now be recorded.
Okay, we are now currently live streaming. You may begin. Thank you.
Thank you very much. Good morning, everyone. It's nice to see you today. We are going to begin the compliance committee by seeking to get some approvals. Apparently, we didn't approve our March minutes, Benton.
Yeah, at the last meeting there was a bit of a rush and we didn't get to that part, so we can approve them today.
That's right. We ran out of time. So I would entertain a motion to approve the March minutes. We have a motion?
So moved, Dr. Caccarella.
And second by Dr. Schottenstein. All in favor? Approved? Aye.
Aye.
Opposed? Same sign. Okay, those have been approved. Then we have the April minutes. Do we have a motion to approve those? We have a motion.
So moved, Dr. Caccarella.
Dr. Caccarella, and a second by Mr. Jackalone. All those in favor? Aye.
Aye.
Opposed? Same sign. All right, both of the minutes have been approved, so we're going to go right into our rule review and suggested changes. We have a lot to talk about with regard to that. And Kim, I think we'll turn that over to you, if that's all right. From what I can see, we're both talking about, at this point, you're talking about evaluations. And later on, we'll talk about questions on our applications, but that'll be later in our meeting. So I'm going to turn it over to you, Kim. You want to talk about your memo?
Sure. Thank you very much. These are the 3 rules that we've been working on in order to bring some other license types into our outpatient evaluation and treatment. And so at the last meeting, we had some questions about the evaluation rule. So most of my comments will be focused there. But in your packet are 4731, 1602, 1605, and 1608, which will all need amendments.
May I just stop you for a moment for those who are listening who are not familiar with what we're talking about? We're talking about our decision to try to bring in our licensees with a lesser degree of education into a 72-hour evaluation versus a full-blown in-house, a one-day versus a multi-day evaluation, which is more expensive for our massage therapists and genetic counselors, etc. So I just want to give them a background before you jump into this. Okay,
Sure.
Go ahead.
Okay, thank you. At the April Compliance Committee meeting, some questions were raised. First about changing psychiatric evaluation to a mental health evaluation. And I have worked with Dr. Schottenstein and with Kelly Long of OPHP, and I believe that she has gathered comments from the treatment providers, and they've agreed that the reference should remain psychiatric evaluation and not be changed to mental health evaluation. So that will remain the same in those two places in the rule. And then we had a discussion about changing a chemical history review to a biopsychosocial assessment. And Dr. Schottenstein had some questions as to whether that was duplicative of a psychiatric evaluation. So I did work with Dr. Schottenstein and with Kelly Long, and OPHP has reviewed this, and they said that it is not duplicative in a substance abuse treatment facility. The biopsychosocial assessment is not completed by a psychiatrist, but is completed by a master's level practitioner, such as a social worker or chemical dependency counselor. And the psychiatrist completes the ICD-10 and DSM-5 diagnoses and medication management. So, so we're going to leave in biopsychosocial evaluation.
Okay, so can I stop you there for the public's understanding, if there is public listening to this? Michael or Kim, could you describe why are we using this more, this term, biopsychosocial term, as a more specific descriptor?
I can take a crack at that. So, a biopsychosocial assessment is, it's a term that's known in the field, right? Everybody who practices in mental health and, substance abuse treatment knows what a biopsychosocial assessment is. It basically is just a comprehensive assessment of a patient that includes biological, psychological, and social factors. And so my initial thought was, with the change that had been proposed, which was, that they were going to remove the, chemical use history and term and replace it with biopsychosocial assessment, it seemed duplicative to me with the psychiatric assessment because that's what we do. But it turns out that in the substance use facilities, when they do their assessments, essentially it is not necessarily a psychiatrist who performs the biopsychosocial assessment, as Kim was saying. And I felt, perfectly fine with the explanation that they gave, which is that, they're going to use a master's level practitioner to do that assessment, and then psychiatrists will stay more with the more sort of biological approach and the medication management and the DSM-5 criteria. So, so that's, I think that's fine. And the biopsychosocial assessment is reasonable as a term because it should encompass the chemical use history term. And so it's reasonable to remove that phrase and substitute biopsychosocial assessment.
Thank you. Go ahead, Kim. I'm sorry. Thank you very much, Dr.
Thanks.
Pleasure.
Thank you. And then the third area where there was a question is previously in 4731, 1605, A3B1, it referenced a structured interview done by specific license types. And so the question was, should the specific license types be added back in? And so we did have a lot of discussion about that. And so the changes that are being made to this rule are actually adding some more clarification to the outpatient evaluation. And we think that we do not need to add the license types because the structured interview is not really being kept in the new draft. The level of evaluation that is now in the rule is a bit more than the structured interview because it includes the biopsychosocial assessment. So the treatment providers use a multidisciplinary team to complete the evaluation steps. And we thought it just might be a bit confusing and maybe too restrictive to list all the license types that could possibly do it. And so the treatment providers are being approved by our board, and they have, the skilled practitioners that are doing this. So we thought that Dr. Schottenstein and Kelly and I, did discuss this and thought we would be okay not including those specific license types in that area.
Thank you very much, Kim. What is a structured interview? Do you refer to it in your, or Dr. Schottenstein or whomever?
That was what was previously in the rule. And Dr. Schottenstein can probably explain that better than I can, but that's what was previously in the rule. We've replaced it with an an evaluation, including the biopsychosocial assessment.
Okay, thank you. Any questions by the committee on that? Kim, is there anything else in your rule review and suggested changes that we need to review?
No, the other changes are just, bringing those license types in to the rule for outpatient, and then doing some cleanup for House Bill 442, which eliminates cosmetic therapists and Oriental medicine practitioners from our license types.
Thank you. We still are. You'll talk about at some point in the meeting, if not in this committee, in the committee as a whole, the meeting as a whole, where we are on cosmetic therapists and your emergency rule, and we've talked about that. It's in place, right? We
Yes,
haven't,
yes.
and perhaps you'd like to just clarify again where we are on that.
Sure, absolutely. We are under an emergency rule right now, which stays in place until August 8th. And it's essentially allowing status quo, allowing physicians to delegate to individuals who were previously licensed as cosmetic therapists. We have permanent rules that the board has talked about quite a bit that are pending at JCAR next Monday, May 17th. We have our public rules hearing on that. And we have received a number of comments already. We expect to receive more, and I anticipate that I'll be coming to you at the June meeting with information from that public rules hearing and the comments that we've received.
And when did you say, how long does the emergency rule last?
It expires on August 8th.
Okay, great. Thank you. Any other questions, the committee, before we go on to Brandy?
I could, what I'm requesting on these particular rules is just to approve them to go to the board this afternoon to be approved for initial circulation.
So Ben, do we have to make a formal vote on this?
So moved.
Okay, so is there can we approve a motion? Can we have a motion to accept the suggested changes that have been presented by our attorney, Kim Anderson?
So moved.
It's been moved by Dr. Coccarella, seconded by Dr. Schottenstein. All in favor? Aye.
Aye.
Opposed, same sign. Okay, you've got a recommendation to go to the full board for a full board vote, correct? All right. So we'll move to the compliance statistics. Brandy?
Thank you. Good morning.
Good morning.
So,
Morning.
as you are all aware, from the ongoing statistics you guys have been getting every month, we have been tracking some things here in the compliance department to kind of figure out where we need to go when we start to have a comprehensive review of the current guidelines, and we maybe start to look to kind of overhaul those a little bit and get them a little more up to date with current best practices. We've been working with OPHP on their programming and have formed a great relationship with them. And so within our compliance department, we're really starting to look at some of the activities that are happening on a month-to-month basis. So that's what you're really seeing in these reports that I've been providing, the complaint tracking, and just the types of activities that have been happening. Our numbers are staying pretty steady as far as number of people on probation with us. We are seeing an increase. There's been, I'd say, a 25% increase in the number of confidential monitoring participants in the last probably 5 months. So that program is continuing to grow, and we're seeing that grow in both mental health and physical health conditions.
So those are self-reporters who get the confidentiality protection by seeking confidential reporting, right?
Correct.
I assume that's pandemic related, or is this just as we're more aggressive or more obviously aggressive, people are stepping into their addiction or their issues?
I think it's just as As the program has become, as people become more aware of it, these are some individuals who had been working with our legal department to get those agreements signed. So they've been working on those for several months. So some may be pandemic related, others are just pending and finally completed.
So we look at the total number of probationers with impairment and non-impairment, somewhat equipoised, right?
Correct.
We have a big change in that.
Not that we've really seen that's stayed the same. We still have pretty equal numbers of impairment versus non-impairment.
And on your charts on compliance open complaint tracking, do you see any major changes there?
So we are seeing that some of the individuals who had open complaints for like the look back, those have been closed out and resolved. And then the others are, we're seeing the complaints like for probation violations. We see that's primarily the complaints that we're seeing coming out of our department. And then as those kind of get resolved and move along, then we have new ones pop up. So those have been pretty steady.
Any questions? Yes, Dr. Feibel.
Yeah, quick question. So, am I understanding this right? So the total number of people is on the memo, the April compliance statistics. That's probation, everything, consent agreements, everything.
Correct.
So, 177 people. How many licensees total does the medical board? Do you know? Does anyone know that by chance?
About 90,000.
Okay, 93,000. So, we talk in a lot of our meetings about how many people are under probationary status and that type of thing. This seems exceedingly low to me as a percentage. So, from a medical board ability to monitor people, when I know at one of our meetings we talked about, we don't want to put somebody on probation because it's, we have so many on probation already. We don't want to kind of water it down, so to speak. I was surprised to see it's such a low number, because to me, 177 does not seem like a lot. So that's good to know in the future for considering putting somebody on probation, maybe, that the numbers don't factor into that.
Well, I with all due respect, Dr. Feibel, a question would be what can the board do legitimately with those probationers, and what is our capacity to do a legitimate probation as opposed to a checklist probation? And Brandy, you might be able to respond to that.
Yeah, thanks, Betty. That's exactly what we're looking at, the number of people that are that checklist type of probation versus the number of licensees that we have who really need to have ongoing monitoring, the ones who have a history of maybe impairment or misconduct, who are actively treating patients. So, I think we're continuing to kind of identify the difference between those groups, and then how to best effectively monitor each one of them. So we do have the ones that we want to make sure we really are keeping an eye on. And then the others that we're also keeping an eye on, but maybe from a lower level of just, a little more check boxes, making sure they're doing their educational pieces and so on.
So what's our staffing for probation department right now?
We have one compliance officer, Angie Sturgeon, and she monitors all 177 licensees. I monitor all of the confidential monitoring participants. And then One Bite is tracked by one of our program administrators and myself.
One Bite is actually monitored more intently with OPHP, but we're keeping a liaison. So, Dr. Feibel, that may answer one of the questions with regard to we're trying to move from peanut butter to a peanut butter approach, which is sort of a checklist, to identifying where we actually have real risk and focusing on the real risk failures or potential failures. I think that's where you're trying to move us. And Stephanie, in terms of staffing, because I think that's a legitimate question, as Dr. Feibel raises it, does this indicate to us that we need different, more staffing here, or what is your what's your future approach to this?
Yeah, it does. And we're actually, so a couple of things. I'm going to circle back to Dr. Feibel's original question, which is, does the number seem low? I think my gut check tells me it feels low, but again, balanced with Betty's comment on the staffing, it's the doable number right now. Because what we don't want to do is add too much into the system and not be able to monitor it, right? So we are in the process of adding staff to this program, because what we would really like to do is get to that more substantive probationary review. We've had some conversations with secretary and supervising member about that, and I know that's a strong desire of theirs as well, that we really concentrate on the substantive piece of that probation. So I do think we'll be able to look at that a little more closely. And then I think we just need to be, kind of a little more strategic about our relationship with OPHP, and possibly others. What other avenues are there for us to increase probationary mechanisms so that we could actually potentially have more licensees under a probationary status? I think that's one of those things that we're looking at when we're looking at our sort of voluminous caseload to say, what are our tools in the toolbox for getting things to resolution? And I think if we felt better about some of those tools, we would be giving the secretary and supervising member more options for recommendations and kind of just really where to go with some of these, even with the reports and recommendations coming out of the hearing unit. So it's definitely on our mind. I think we're managing it right now. We certainly could use more staff, but I think there are other tools out there that we need to explore as well.
So we're looking to supplement using OPHP perhaps with some of their with some of their expertise, and we're looking at different ways to do what Dr. Feibel has expressed a concern about is be able to do more substantive and real probation matters. So right now we're constrained by our staffing.
I think that's fair. Yep.
Brandy, is there anything else in terms of your presentation?
Not in respect to statistics, just wanted to give an update that we have started a project to make some changes to the website for compliance. So we're working really hard on that, updating information that is on the website, updating resources and tools for our licensees, for our providers, and for consumers.
Great. And do we have any questions for Brandy? If not, can we turn this over to Stephanie? We have a couple of loose ends. The application, we have a number of things that are sort of in the wings, still being worked on, our application questions, and our compliance audit processes, both before and after disposition of a matter, post and pre. So those are a number of things that are still pending in this committee, waiting for some conclusions. So we'll turn it over to you and see what you have to say there, Madam Executive Director.
Thank you. So I just wanted to give a status update. We've been working pretty closely with OPHP on a variety of matters. And so what we bring to you every month sort of gets us to, we bring you sort of the finished package when you're seeing it. But I don't want that to reflect kind of all of the good conversation we've been having with our partners in that program over the past, I would say, Brandy, 3 months maybe? We've been meeting, on a kind of an every other week or every 3 weeks basis to go through some process mapping with OPHP on the One Bite program and on other matters as well, given their expertise working with our licensees. So, I think that you've heard me say this before, we're into a little over a year of operationalization of the One Bite program. And this is, I think, a really good natural time for us to be looking at how is the program working and where can we make some changes that make the program better. And so we've been looking at 3 areas where we could accomplish those changes with OPHP. And it would be either in statute, actually 4 areas: statute, rule, contract, because we have a contract with OPHP, or just policy, just a policy decision on changing direction in a different, way. So a couple of the things that we've, worked through in those meetings, we've talked about in this committee, and actually have going forward, we have some statutory language drafted that we would be requiring people to timely report OVIs to us. We would make it mandatory that they would report to us. We think that will help us tremendously in the evaluation turnaround with OPHP. Sometimes by the time we get those reports and renewals, they are beyond the impairment definition even. And so by the time they go to OPHP, there's really no basis even for an evaluation. It's a very simplistic way to say that, but both sides, OPHP and the board, think this would be very helpful in getting those who need to get into treatment in a more timely fashion.
Stephanie,
yes.
You'd have to not limit it just to OVI, DUI. You have all related offenses because of DUI reduced, or you've got domestic relations issues that involve alcohol, blah, blah, blah.
Right. That's why I'm not allowed to be a lawyer at the medical board. They've taken care of. Okay. Thank you. Yes. The second thing that we've been talking about with OPHP is how can we provide more information to them and still keep things confidential from our investigatory matters, but provide a more substantive referral to OPHP. So we are working on this, and Kim, that's sort of on Kim's plate right now, again, on a drafting perspective. So we're kind of working through that, but we think that will also make big improvements into who gets into treatment quicker, and it will just give more information to OPHP to build off of when they are presented with that licensee. Right now, it could be as simple as them receiving an email with a name and an address, and they really don't know how to approach that individual or under what circumstances. So I think we'll get better results if they have more information, but we also have to be cautious to not give information that's harmful to our board. Dr. Schottenstein, did you have a question about that? You look like you may.
You could tell. So I was just sort of thinking a couple things. One is in terms of the timely report of the OVI, I think that's a great idea, and certainly everything related to it. But what about just crimes in general? In other words, any convictions that typically have to wait until the following renewal, we might as well just have people, report all of their convictions our way, which would then include OVI and other related matters. And then the other thought I had in terms of, I know OPHP came to us before with this question about could we provide more information when we refer to them. I guess I was just sort of kicking around in my mind, is there a way to categorize them as an F5 entity? Is there such a possibility? Because that would solve our problem in that regard. In other words, even could we make their status sort of unique that way?
Sure. So we'll take the 2 separate questions. I don't know, Kim or Nate, if you want to address the first on the reporting. I do believe that we have it drafted as any conviction or crime. Nate, is that right?
Yeah, I think. Well, I know that's what we suggested, that instead of waiting, we bookend. Prosecutors are supposed to tell us, and we're bookending by requiring the defendants to also report. That's what we had suggested, Dr. Schottenstein.
Right, in that, yeah.
We do, in our draft that we're working through, we do have the self-report of a criminal conviction. So So that is feedback that was given that has been incorporated.
Great. And then Kim, do you want to address Dr. Schottenstein's F5 question?
Absolutely. Yeah, and sure. So I think in the contract that we have with OPHP as monitoring organization, we are looking to add language very similar or identical to what we use for expert witnesses. So, when we're having experts, we give them the F5 material that they need in order to do their job. And so I think we're looking to add that language into the contract. Then I think we'll need to talk about what does that look like, as we're giving it, but the contract will give us the authority to do that. We haven't had that language in there in the first contract that we did. So I think that will solve that. And then, we'll figure out the best mechanism, to determine what to provide.
And Dr. Feibel, do you have a question?
Yeah. Just more of a comment, and it's a little in the weeds, and I don't mean to get in the weeds, but I think it's important to say, I always say that 99+% of our licensees want to follow the rules when they're given to them. And so if we're making this change of having to report a conviction before a renewal cycle, we need to really make sure that it is out in front of the licensees so they know what the expectations are, because right now that is not an expectation. And so I don't want to get a gotcha moment of a licensee to say, oh, you didn't report to us, and it's somewhere hidden in the thing. So that might be part of the renewal process immediately once we do it. That's a question that says, do you understand that if you are convicted of a crime, you need to report it to the medical board immediately?
Yeah. That's a great idea. And yeah, we'll have to build, I think, an entire kind of rollout package around it. I was actually thinking about when we do our annual duty to report video updates, we could also include it as a reminder in there. And we'll do, that will be a big change that we'll need to roll out to licensees. We'll have to do a really organized sort of campaign around that, I think.
And maybe a grace period. Until the licensees.
I would imagine. I would imagine that's because again, we don't want to be in gotcha. So I think that's.
Thank you very much. That's a good point. Stephanie, do you have Miss Luca? Do you have anything else that you?
I have a whole list. If I may, if that's cut me off whenever you're ready. We talked a little bit ago about us including staff in this unit under Brandy's direction, and part of what that staff will do, in addition to what we talked about with respect to sort of a more substantive probationary approach, is also a more substantive treatment provider approach. So we're really looking at the provider applications right now. How do you become a medical board provider versus how do you become a one-bite provider? Those processes differ a little. We've heard from the community that that's confusing to providers. It's confusing sometimes to licensees. So it's sort of like peeling an onion. There are different parts to different applications that work well. So we're sort of trying to mirror that process now that we know that it's working, and try to get to a streamlined, how do you become a treatment provider in the world of medical board compliance? Is probably the simplest way to say it. And then what sort of eyes are we putting on those treatment providers, right? And so I would say that's something that we really need to work on, is from a reassurance perspective, how do we know we have the right treatment providers out there? So that's something that new staff will also be concentrating on.
Back up on one thing you said, as you talked about the probation department needing more staff, and then us looking at how do we approach use of those staff in a more substantive, in a meaningful way. You might want to talk about what you want to do with your investigators.
Sure. I think it's kind of an all hands on deck sort of thing, as we figure out what availability looks like, and what, I think everything's on the table for figuring out how we accomplish that.
You mean you want to move some of your probation folks who would want to be able to go out in the field sometimes, as opposed to just sitting behind the desk.
Absolutely. Yes.
Okay. To avoid a checklist probation, actually going out and seeing in an unannounced way what's actually happening, where you have probationers who could be potentially more problematic, more dangerous to the community.
That's
Okay,
right. A little away from that paper list and sort of the eyeballs.
Yeah.
Two issues that OPHP they're exploring right now. The first is the idea. I think we've talked about this a little bit, and we're waiting to hear back as they gather more information and think about their resources. We have so many licensees who go to OPHP under one bite and end up not impaired and not needing to go to treatment, right? And so they have a good feeling on a lot of those folks before they go through the evaluation that they may not be impaired. Now, we will certainly be cutting down on that population with that mandatory conviction reporting, right? Because a lot of those folks are the people who may have had one incident that does not indicate a sign of impairment. So they are exploring, is there a service they could provide where they, in very limited circumstances with the right guardrails, do some sort of preliminary assessment before an evaluation. Because, as you know, these evaluations are 72-hour evaluations. Sometimes they're very costly and they're hard to get into. So, we would be very cautious with it. I think we would be, it would, for lack of a better phrase, it would be sort of the no-brainer situations that, wow, this person is really not impaired, and we are sending them through an evaluation when we know they are not impaired. So I would say just stay tuned for that. I'm sure that this will come with concerns from the board, I have no doubt, and appropriately so. But I think it's worth hearing, just for our licensee's sake, is there an option out there that maybe they shouldn't be going to an evaluation, right? Does our structure need to have something else built in? It's not a one size fits all. If we think this, then this means 72-hour evaluation. Is there something that precedes that for certain circumstances? So I guess stay tuned on that. We'll obviously have a lot of discussion if we see something like that come through. Additionally, OPHP right now, we've had conversations in the past about what's a relapse and what's a slip. And we've even had conversation with our internal staff where the rule was created so long ago that maybe the science has changed a little bit in our definitions. And so we're leaving that to them to come forward to make a proposal to us to say, using their clinical expertise, make a recommendation on that language on relapse and slip. And then I would say, finally, that one of the things we've had some conversation about before, and we continue to have ongoing conversation with OPHP about, is that ability for the PHP to PHP transfer. So this is, right now, we do not have this ability in law for an applicant to bring their PHP experience into and become then a PHP participant in Ohio. That's not allowed in law. We've had ongoing conversations with OPHP about this, and they actually brought this back to us in light of the interstate, the compact that is potentially looming, that this may become even more of a necessity given the compact with licensees coming in from other jurisdictions. We've heard from Kelly Long that we're one of the only states that does not allow this, and that it's a real deterrent to applicants sometimes that they are not able to just transfer their PHP participation coming in as a licensee. So, I think we've had conversation about that. I don't know that we've ever fully rounded out that issue, but I think that OPHP is desirous of exploring legislation that would allow us to do this PHP to PHP transfer. They see it as a very low risk for public safety change.
So, Dr. Schottenstein.
Will it in fact require legislation, or could we do it in rule?
We would need to make a statutory change.
Are you, Stephanie, have you gone through your list, or you're just
That is my list.
Well, can we talk about, so also pending is a discussion about our questions, our application questions, and also pending our coming back with proposals with regard to the guardrails, both the audit, the quality control issues, both while cases are pending and post pending. So did you want to update us on that, where we are on that?
So we can move maybe to the application questions, but I would like, I believe that OPHP will go forward with some legislation on that transfer. And so we've had a conversation with them that they would like that language. And I know we're in the budget process. So I would like us to maybe have some discussion on that or hear any concerns about that before we move on to the application questions. But yes, let's talk about the application questions as well.
I'm sorry, I'm not sure I understand what you're saying. Okay, so we're done talking about OPHP. I know I'm asking you about the application questions. So
I guess I'm asking, are we done talking about OPHP? I can very much see this coming up as legislation. And if there are any
bring us a whole package of legislative change.
I think what I'm saying is that we might not be driving this legislation. This legislation may be driven. And so if the committee has concerns, I would like to communicate those back to OPHP on the transfer issue.
Do we have anybody have any concerns? Okay.
I don't have any concerns, but I support it in concept. I think that there should be a vehicle through which we can do a PHP to PHP transfer. I guess I'll leave my remarks at that.
Just a question, Stephanie. I mean, if we do the PHP to PHP transfer, does that mean that anybody who's in a PHP program that we typically would not let or approve to get in the state all of a sudden gets in the state?
So it would be somebody who, right. So let's, if the other state that they were transferring from allowed that individual in their PHP program under a different set of circumstances than we would, they would come in under our PHP program, right?
Right.
So the question would be then, is there a scenario where, yes, the simple answer is yes.
Yeah.
And I don't know what all of the initial qualifications for other state PHP programs will be.
If you have a more lenient PHP program and a more lenient board, they give that individual a slap on the wrist. We're all of a sudden obliged to take them in as is, even though in our state we might feel like that's a no-go.
Right. So I guess what I would say about that is that the positive to that would be that they would be automatically entering into a PHP monitoring program, as opposed to going through the process with us where there might be a gap period between their licensure and us taking enforcement and us reviewing. And I think we have a PHP program that's a pretty sophisticated one nationally. So I think we actually catch things faster than some of the other states because of our level of PHP, right? So said a different way, they're coming into a program that is quickly going to notify us if there's a problem.
Okay.
That being said, if we were sending an Ohio licensee to another program that might not be as well run, I might be a little more worried about our transferring out of licensees. I mean, their state's problem at that point, right? Not our problem anymore. But I do think that given our program's reporting and our requirements that we have for them to report to us, it's sort of a safer bet on our end to get them into that OPHP program.
Okay. In the program, just to clarify, this involves just substance abuse, or this can involve everything, mental health, everything, right? Technically, or not? Or is this pretty much?
No, this would just be what would be considered our kind of one bite, if you will.
Fine. Perfect. Thanks.
Okay, so back to the application question.
Back to the application questions. Yes. So relatively, I think recently, Dr. Schottenstein shared an article about about the state of application questions. As a reminder, we currently do a 5-year look back on our application questions with respect to impairment, physical or mental or substance. And so, Dr. Schottenstein, do you want to talk a little bit about the article that you sent?
Yeah, it was the journal. It was from the Journal of the American Academy of Psychiatry and the Law. And essentially, what it looked at was medical licensure questions about mental illness and compliance with the Americans with Disabilities Act. And, you know, we had a substantial discussion in a previous meeting about the look back and how far back we should look, and you know how we want to make sure that our look back is constructive, not punitive, that it serves a purpose, but at the same time, of course, that we protect the public. And I was concerned about whether or not we needed that full 5-year look back. But when I was reading this article, Ohio was actually singled out for the application questions that we made some years ago. Some of us who've been on the board long enough may recall that when we sort of took a look at the application and made some revisions to it. And, we were singled out in such a way as to say that the author's conclusion was that we clearly met criteria for following ADA. And, that gave me a lot of comfort, just speaking for myself, in terms of staying with the 5-year look back. I still would be okay with shortening it, but I'm also much more comfortable leaving it where it's at if that's the consensus of the committee.
I think, I know where I am. I would, and I think I know where Robert is, and I think we both felt that the 5-year look back gives us a better complete look at matters over time. And I don't know if the committee has any feeling about that one way or another.
So again, just speaking for myself, I'd be comfortable staying with 5 years for what it's worth.
Is that okay with the committee? I think we'll leave it at 5 years. Is that all right with all of you? Anybody objecting? If not, the application, I must not be specific with you, Ms. Luca. The questions about language that we're asking on the application with regard to mental health and all of that, I know we addressed some of this discussion in rules but generally speaking, we're still working on that language. Is that what? Okay.
Yeah. So I think we had a threshold question on the years as well, but I think that's we did make a host of changes to the initial questions, except for the mental health and impairment questions. So we're still working on those, and that's something we'll bring back once we've made a little more progress on the exact language.
When do you think we might be able to address that application question? Do you think by summer by June we might be able to clean up the language?
I think given through some of the things we've already checked off the list today, I think June seems very reasonable.
Okay. And with regard to the compliance package, and this is a more complex question about where do you put a consumer member at rounds, and where what do we do on quality, our quote audit process afterwards. You're still working on that process?
Yes, so we are not having that committee this month because that involved some technical changes so that's the work that we've been doing under the FSMB recommendations committee, the inclusion of the consumer member and the quality assurance process. We are working on some mock-ups of some kind of workflow of how that quality assurance would work in Salesforce. And we thought it would be a little easier to talk through that if we had a tangible to kind of anchor that conversation. And so that just involves a lot of Salesforce type work and decision on what to include. So we'll have that committee again in June. So we'll bring that back in June as well.
Okay. Is it are we able to, I'm assuming this summer we'll have a retreat and perhaps we'll be able, I don't mean to assume anything, but assuming we have some kind of sort of retreat where we talk about our process reviews and all of that, it would be nice to have our quality review stuff done in a timely, do we have a sense of what the time might be on that?
I'm not sure I'm following.
Okay, so if I want to know, when are we going to start inserting some quality review for FSMB and in the rounding, and when are we going to be doing our quality control and quote the audit or theme and variation thereof? What time when do you think we might be able to think that we can start implementing anything like that?
Well, so the addition of a consumer member to that process requires statutory language. So we would need law to do that. With respect to the quality assurance process, I don't have a good time estimate at this time. I think it's a matter of getting the systems created and figuring out who's going to staff that, because I do think it will require some staffing. So I would say, we would need to wrap up with the committee recommendations and then build that out. Once we have the committee recommendations finalized, I think we'll have a better sense of timing of when we would start something.
So we can say for Benton's sake that we're still working on it.
We're still working on it. Yes. Very well.
Okay. Are there any other issues pending, members of the committee or anyone on the call here that we need to address or that are pending or are issues sort of circulating within this committee that we haven't talked about? If not, I think we're done with our agenda. If that's the case, do we have any, Nathan, did we have anything you need to add, or Kim or Brandy? Anything else? If not, then I think would entertain a motion to adjourn the committee, and we will be re-upping ourselves in 6 minutes for the full board meeting. Do I have a motion to adjourn? Dr. Coccarella, seconded by Dr. Feibel. Thanks so much, folks, and we'll see you on the other side. 6 minutes.
Could we have someone who's a member of the committee second that motion to adjourn?
I'm sorry.
Because I see Dr. Schottenstein did. Thank you very much.
Okay.
And just a quick voice vote would be nice.
Aye.
All in favor?
Thank you.
All right.
Thank you so much. I appreciate it.
Okay, we'll see you in a few minutes here.
See ya.
This conference is no longer being recorded.